it was predicted that 1 out of 4 people experience mental health at some point. Now, this prediction was in 2001. Currently, we've got 450 million people worldwide who are dealing with these issues right now. And when I say these issues, I mean mental health issues and different type of mental health illnesses and disorders. And among these actually have contributed or attributed to the primary causes of ill health and disability worldwide. So this information was gotten from the World Health Organization. Before I proceed further, with reference to my topic of discussion today, demystifying. Now, like I mentioned in my preamble, there are a lot of myths in the African context regarding mental health. And I'll mention some of the few myths that we discovered during our interaction with people from a few parts of Africa. So mental health problems, the first myth is that mental health problems are uncommon, meaning they feel mental health issues are scarce and it's very peculiar when it happens or they discover that somebody has it. The other myth that we discovered was people with mental health conditions cannot work. Ladies and gentlemen, colleagues, you might agree with me that it's very rare to find our friends with mental health conditions working at any place. When I say rare, I'm not saying you cannot find. They are there, but there are certain conditions such as intellectual disorders. You find a few people and there's a lot of discrimination. The third myth is that mental health problems are a sign of weakness. I'll give an example of the context of Zambia. Zambia being part of Africa, an African child, especially a boy child, is told to be strong, regardless of the circumstance that he finds himself in. So when somebody exhibits signs of mental health related issues, they attribute it to a sign of weakness. The fourth myth is that only people without friends need therapists. So you can see that there's a myth and a misconception of the need of just talking to a friend and not to a therapist. Colleagues who have been practicing in the African context, you agree with me that the number of access to primary mental health services are very low in most African countries. In the Zambian context, it is at only 3% access. People will come out to access primary mental health services. The fifth myth that we have in the African context regarding to mental health is that mental health problems are permanent. This type of myth, once you tell somebody that I've had a mental health related condition in the past, they will feel you're still a patient. So they do not feel that these mental health conditions can be treated at some point. The sixth myth, very funny, but in reality, is that eating disorders only affect females. And this myth has been going on. Eating disorders, in reality, they can affect anybody, but the myth is that only affect females. The last amongst the myths that we gathered was that all people with mental health, mental illnesses are violent. I think this myth is out of the 54 states that we have in Africa. It was very prominent in about 38 countries in Africa where they thought that mental people with mental illness are very violent. We proceed, ladies and gentlemen, after looking at those myths that we have, I want also to move to the history of mental health in Africa. Ladies and gentlemen, you might be interested to know that the African timeline is divided into pre-colonial, colonial era, and the post-colonial era. Now, mental health was trivialized, especially amongst traditional societies. People with mental health issues were, should I say, were once stigmatized by society. Some people held the view that mental illness was caused by malevolent spirit or divine virgins. Most of the times it will be attributed to being bewitched in the African context. So although there are peculiar methods that they used, which one of them was to see a traditional medicine man or a traditional doctor. They used juju or umuti in the African context to try to cure, and they had performed other traditional practices that they believed that would send away the evil spirits upon that person. So although these methods of thinking has largely been eradicated from society, their influence is still felt everywhere. Up to now, I've got colleagues who have attained the highest level of education, but they still think when a student at a university has a mental health issue, they will still feel that the village people has something to do with it. Funny enough, but reality. Now, we before the introduction of colonial education, we had, like I mentioned, traditional method. One typical example of a traditional method, ladies and gentlemen, was the aspect of teachings before somebody went into matrimony. People, especially women, were told that a home is a place of survival. Whatever traumatic events that you might face, you shouldn't bring it out of the bedroom or out of the house. So a lot of women and men suffered gender-based violence, which is number one cause of mental health related issues. And it went like that for years. Now, during colonial time, we had what they referred to as colonial mental asylums. During colonial times, because of certain treatments by our colonial masters, some people had a lot of mental health related issues. And the only solution was to lock them up in mental health asylum or mental asylums, which were dotted around many societies. So post-independence, ladies and gentlemen, I'll move to now what is known as the contemporary trends in mental health in Africa. And right now, there has been a lot of demand for mental health services in Africa, particularly amongst the vulnerable ones are women. Like I've mentioned, women, because of traditional practices, are thought to be a vulnerable group. But research has not proven yet. There are a lot of studies that have speculated, but there hasn't been sufficient evidence to prove this. So the other point is that most African governments have devoted less than 1% of their budget to mental health services. This was a case with at least more than 30 countries in Africa, where only 1% of the total budget, especially the health budget, was dedicated to mental health services, which is just a drop in the ocean, if you ask me. So there is the dearth of policies and the strategic plans, especially for child and adolescent mental health. In African context, we do not believe, in most societies do not believe that children can be affected by mental health conditions. as well as adolescents. So there hasn't been a lot of devotion in terms of taking mental health services close to children as well as adolescents, such as maybe devising a curriculum that can be taken in secondary schools as well as primary schools to sensitize children about, and as well as adolescents about, mental health. Furthermore, the Mental Health Atlas 2020 report reports that only 49% of member states in Africa, in the African region, had mental health legislation in relation to financing the average government budget allocation to mental health, which was about US dollar about 0.46 per capita, against the recommended US dollar 2 per capita for low-income countries. Now, you might relate, ladies and gentlemen, that in many African countries, we have an issue of the shortage or lack of or limited mental health policies. In my country, they devised one in 2019, which is not functional because there's no board that can run it. I think this also spills over to other countries where we notice that there hasn't been a mental health policy. Further, there's a challenge in terms of scarcity of human resources, with shortages, poor geographic distribution. For example, in the Zambian context, we have 10 provinces. Out of 10 provinces, we only have 4 provinces that at least have one psychiatrist or psychologist serving that population of over maybe 60,000 people. So it gives you a picture of how human resource has hit the African context. So the distribution, this has been supported by the WHO report of the year 2022 concerning human resource shortage of distribution, and as well as weak competencies and maldistribution of specialists in these areas. Ladies and gentlemen, allow me to move to the factors that have contributed to practice and access to mental health in Africa. The biggest factor that has hindered access to mental health is traditional practices, like I mentioned. In my country, Zambia, there is a saying which is directed to a man, and in my local language we say Mwamuna Sarila, meaning a man doesn't cry. So in the African context, whether your wife dies, your loved one dies, your relative dies, you are supposed to be strong and not shed a tear. Now, you know that creates bottled emotions that later on affects the person. Other traditional practices are issues of early marriages that takes a child into matrimony before they are psychologically ready. The others are issues of premarital teachings that keeps certain gender-based violence. One of the participants that we asked in our short research, he accepted of beating the wife physically because he thought it was a way of instilling discipline in the African context. And then another woman attributed silent treatment of the husband in a home. Now, those are traditional practices that have been going on, and they have really affected the practices in terms of mental health access. Another one is, you find a young psychologist in the African context who is 28 years old, and this is a client who is 60 years old. In an African setting, they will not consider that session to be viable because of the age differences and all that. Apart from traditional practices, ladies and gentlemen, The other contributor or the factor in terms of practice and access to mental health in Africa is religion. There are certain clients that has been brought to our facilities in their last stages of their mental health illnesses because some man of God out there told them this is a spiritual problem and we can pray for it. And we find that a lot of people shun accessing mental health services in these hospitals and private practices because of issues of religion. The other point that, the other factor that has contributed to practice and access to mental health in the African context is policies. Access to mental health policies, like I mentioned, manpower as well as funding. So there hasn't been a lot of deliberate policies in the African context that really should hold government or the system responsible that everybody has a right to access mental health services. The other one, the biggest one of all, is stigmatization. There's still stigma because of myths, misconception. So people cannot access mental health services because of the tag, the negative tag that people have about those mental health facilities. There's also the aspect of financial strain that I've mentioned, poor awareness. There has been very poor awareness in the African context regarding mental health illnesses, as well as services. The other one I've mentioned also, it falls under policies, is social, cultural, and religion. Allow me to move on to my conclusion, ladies and gentlemen. There is still numerous myths and misconceptions around mental health, despite the area receiving more attention and research in the African context. Sadly, there is still a lot of stigma around mental health issues. Most of it is based on obsolete presumptions and outdated thinking. Like many other things in life, the more knowledge we possess, the less probable it is that we will allow myths to sway our judgment. What is our way forward, ladies and gentlemen? Firstly, Africa needs to invest in mental health as an urgent priority. And when we say investment, we mean in all sectors of mental health, such as academia, private practice, the health fraternity or the health sector, and other sectors that are related or that are vulnerable to mental health issues. The second way forward, or suggestion or recommendation, is that since it was discovered in our interaction with the people on the ground that an African person would rather talk to a friend about their mental health status, so we need a peer-to-peer strategy that will sensitize many people, and they will know how to react when they receive a peer or a friend in terms of advice regarding to